Hi, everyone. So I took the opportunity to do a little bit of learning about COVID-19. I've attended a bunch of different webinars, as I'm sure all of you have. The most recent webinar that I attended was last Monday, and it had a number of professionals on it from Alberta Health Services, from Edmonton, Calgary, and other parts of our province. And one aspect of the webinar was some basic science that all of us are probably lacking with regards to COVID-19. Dr. John Connolly, who's a professor at the Cummings School of Medicine. He's also director of infectious disease prevention and control in the Calgary zone and a member of the World Health Organization panel on infection prevention and control. He was brilliant to listen to, a little smarter than the rest of us. A lot of the slides that I'm going to present today is information that he presented on that webinar. And then I went to a lot of the resources that he used, and I'm going to provide you all with some links to some articles and other resources through Alberta Health Services, just to kind of bring all of this to an understanding for all of us. So I hope it makes some sense. Obviously, we can talk about it some more and maybe even set up a Zoom meeting to review, but I thought I'd get this out there now for everyone. All right, so objectives of this course or of this presentation. Number one is to review some of the, quote, basic, viral facts, a little bit about the virus. I'm not going to get into crazy science, just some of the things that are common sense for us to be able to understand and even communicate to our loved ones who have almost no science background, potentially. Understanding how the disease is diagnosed and some evolving treatment options. And of course, none of this information is mine. It's information that I've gathered and learned from all of the intelligent geniuses out there. Just wanted to share it with you in a concise form. Current scientific topics about the disease, kind of weeding through all of the noise that's out there, and then implementation of advanced PPE for dental emergency care. So obviously at the end, we'll talk a little bit about how all this applies to us and kind of put some of that into focus. So SARS-CoV-2 is the virus that causes COVID-19. So this is what it looks like. Quite pretty, actually. So some information, some viral facts. So SARS-CoV-2 or CoV-2 is the virus that actually causes COVID-19. So COVID-19 is not the virus, the other SARS-CoV-2 is. It originated from bats, as we all know. It is a single-strand RNA virus in the coronavirus family. And so it's a pretty simple virus. It's easily killed when it's on surfaces with just household cleansers like Lysol, diluted, what am I trying to say? Bleach and wipes, as well as just hand washing properly. So it's not that strong of a virus, but unfortunately it is very pathogenic. All right. It is a respiratory virus, and I'm going to give you a little bit more information about that. Some of this you'll remember back from biology. And it is transmitted by contact droplets. Right now, it is not believed to be an airborne type of transmission, but the jury's still out on this. There's some research and some articles that I'm going to tell you about, and unfortunately some misinformation that's out there if you don't really delve into all of that research. Other viral facts, it uses human ACE2 receptors, so angiotensin converting enzyme 2 receptors, which are found in respiratory epithelium. So it uses these receptors, which is why it attacks everyone's lungs. It has a very high affinity for these receptors. It's very sticky to these receptors, and it only really takes a little bit of virus to start or initiate the acute infection. And of course, individuals who have any sort of respiratory diseases or comorbidities, they're obviously going to be that much more prone to this infection. It's a weak virus, but it does have a high pathogenicity. So the weakness of it, unfortunately not from a cure standpoint because we haven't developed a cure yet, but the weakness of it is that we can eliminate it in our environment by proper hand washing and then cleansing of surfaces, and it doesn't require like really heavy duty cleansers to do so, which is a good thing, right? A vaccine is not yet available for it, and no one at this time is, quote unquote, immune to it yet. We're still kind of building that immunity. Obviously, people who have had the virus, who have recovered from the virus, are now considered an immunocompetent host. That's a term that I learned a little bit more. So diagnosis. So diagnosis for the virus, it has to be properly done with either oropharyngeal swabbing or nasal swabbing, and it just can't be from the cheeks or from the anterior part of the nasal septum. It has to be way far back in the oral pharynx or the nasopharynx. It's very important, Dr. Connolly brought this up, that cells actually have to be collected. The problem here is that earlier swabbing techniques were from the anterior nasal region and maybe even from the anterior oral cavity. And unfortunately, because of that, there are some false negatives that are out there. Individuals who are performing these tests do not have to wear N95 masks. Those are not required. There is a two-step process. I don't know a lot about this, but what it is that it first identifying the what's called E gene coronavirus sequence. Then that is confirmed by the SARS-CoV-2 polymerase gene. Right now, globally, there is a severe reagent shortage in order to do all of these tests. And as we know, more and more tests are becoming more and more available. Alberta's done a great job because we've done more testing in Alberta than I think any other province. So we're really doing a great job on this. Sampling and timing of the test can actually create issues. So if you do the test too early, or if the sample is not a good enough sample, you don't have enough cells, that's going to alter the results and maybe even false negatives. And there are questions whether the virus sequence found post-recovery means active infectious disease, and the jury's still out on that. There is no serology testing yet. They're unable to determine past asymptomatic exposure as a result of the no serology testing available yet. So asymptomatic patients, this is something that we're all dealing with in practice. We don't know whether or not the people that we're actually managing who during our pre-screening who are coming across as asymptomatic, whether they're actual carriers. And you know what? Nothing is really different in the medical world that way as well. There's a lot of research out there. I think since January or maybe even December 2019 or January this year, there's been so many articles published. Unfortunately, a lot of them are not giving the most accurate information, but no one really has a final answer on this. But there are some recommendations. So the proportion of asymptomatic infections up until today are unknown, but there are some facts that they have or do know, and they have kind of clarified. So number 2, the incubation period after someone is exposed can be anywhere from 2 days to 14 days, and they say the median is 5 days. Approximately 98% of exposed people develop symptoms after about 11 days. So now those 98%, about 80% of individuals who have diagnosed symptoms usually have self-limiting disease. So the symptoms are pretty mild. I mean, not necessarily only mild, but it is self-limiting. It takes about 14 days to go through the whole process of it, and they get better. Unfortunately, 20% have more severe illness, and these individuals require more medical care and even hospitalization. And of those, 5% of the group have the most severe, and they require the ICU admission. They can develop multi-organ failure, they require ventilation, and they have a higher risk of death. So, overall, there is still a very small percentage of the population. As we know, the elderly are more susceptible, and that often is because of the fact that they have higher comorbidities, higher rate of comorbidities. and they're just a weaker immune system that potentially makes them more affected. But younger people have died from it, obviously not as many. This is a comparison table between the influenza-like illnesses, or ILI, and COVID-19, and you can see that there are some similarities, right? The fever, the cough, the myalgia, fatigue, just feeling tired, muscle and joint pain are between both of them. Other things that you will see in COVID-19 later, also sputum production, shortness of breath, sore throat, headaches. Anosmia means the lack or inability to smell. Hypoosmia is, sorry about the crossover here, decreased ability to smell. Dysgeusia is inability to taste. And then nausea and vomiting, a lower risk, but also present. So there were a few tables that I looked up from the World Health Organization. And again, this is 2020, showing the percentage. So most common signs and symptoms, 55,000, almost 56,000 laboratory confirmed cases. COVID-19 reported from China in the period up to February 22nd, 2020. So literally a couple months ago here. Fever being the most common at almost 88%, dry cough almost 70%, fatigue 38%, sputum production, shortness of breath, muscle pain, joint pain, sore throat, all the way down to nasal congestion, diarrhea as well. For all of those who hoarded up on toilet paper, unfortunately diarrhea was only about 4% of the cases, but it's still a percentage, so hopefully it'll come in handy. Then you've got this chart as well. Sources are from the CDC, from WHO, from American Association of Allergy, Asthma, and Immunology, also available online. You can see comparison with COVID-19, common cold, flu, and allergies. So take your time and read and look at all of these, but you can see that there's a lot of similarities, so that can be misdiagnosed as well. So additional testing that's being done, this can get a little complicated. I had to kind of go back into my world here, learning and remembering all of these different tests. But one of the earlier things to remember is that the white blood cell count does decrease, also known as leukopenia. Sorry, this should be lymphopenia. Error there. Elevated liver function tests. So liver function tests, also referred to as a hepatic panel. They're a group of blood tests that provide information about the state of the patient's liver. Tests include PT-INR, activated PTT, albumin, bilirubin, direct and indirect, and others. And you also have LDH, or lactate dehydrogenase test, and that looks for signs of damage to the body's tissues. So LDH is an enzyme that's found in almost every cell of your body, including your blood, muscles, brain, kidney, and pancreas. And the enzyme turns sugar into energy. So the LDH test measures the amount of LDH in your body and other body fluids. The CRP, or C-reactive protein, it's a blood test marker for inflammation in the body. CRP is produced in the liver, and its level is measured by testing the blood. CRP is classified as an acute phase reactant, which measures its levels, which means that its levels will rise in response to inflammation. And then ESR, or erythrocyte sedimentation rate, is a type of blood test that measures how quickly erythrocytes, or red blood cells, settle at the bottom of a test tube that contain a blood sample. So normally, red blood cells settle relatively slowly. A faster than normal rate may indicate inflammation in the body. So an elevated ESR means more inflammation in the body. And then critically ill people, D-dimers and interleukin-6 testing shows elevation. They're saying in a lot of the literature that radiology is not recommended as a screening tool. The early you will see on chest x-rays, for instance, small infiltrates unilaterally or bilaterally. However, progression of the disease leads to what they call ground glass appearance, or crazy paving. These are terms that I just learned when it comes to the lungs, and I did put in some images here in the next couple of slides for you to understand. So here is a chest x-ray, a pneumonia patient, whether it's bacterial or viral, causing infiltrates in the lungs, and you can see that. So this is pretty, advanced infiltrates in the lungs, and that's with pneumonia. This is a CT scan cross-section, and this is the ground glass opacification that they see on CT scans. I'm not a radiologist, but this is what I've read. And this is what's called crazy paving pattern on CT scans. And this is much more advanced disease. So these are some of the things that radiologists look for. And now you have an idea of what's going on there. So severe manifestation of the disease. This is a link here. So please make sure you look at it. It's on canada.ca/en public health and COVID-19. So take your time and make sure you visit that link. And so severe disease manifestation can lead to acute respiratory distress syndrome, organ failure, sepsis, and septic shock. And in the next few slides, I actually went to the website and broke down some of that information. So with ARDS, onset within 1 week of known clinical insult or new or worsening respiratory symptoms, some information about chest imaging, bilateral opacities, origin of pulmonary infiltrates, need for objective assessment. So definitely take your time and read that. These are the things that they're seeing in adults with sepsis. So life-threatening organ dysfunction caused by a dysregulated host response to suspected or proven infection. And the signs and symptoms are listed here. Sorry about that. And then for children as well. And then septic shock, adults, persisting hypotension despite volume resuscitation, requires vasopressors to maintain the mean arterial pressure greater than 65 millimeters of mercury, serum lactate levels greater than 2 millimoles per liter, and then information about children. So this is just more kind of detailed information with regards to the severity. COVID-19 treatment, what's going on right now at most facilities. It's supportive care, obviously treating the infection with medications, ventilation if needed, ICU if needed. This is a reference to a New England Journal of Medicine study where they were looking at Kaletra. It is a combination of these two antiviral medications, and I believe Kaletra has been used in combination with other medications for treatment of HIV. They showed in this particular study that there was a disappointing effect of Kaletra for the treatment of COVID-19. However, some of the assessment of this study was that they really used it in a very challenging situation with people with very advanced disease. And this was in China, I believe, that they did this study with this particular drug. So the jury's still out on whether or not this double antiviral is effective, and lots more clinical studies are being done with it. We've heard about this hydrochloroquine, azithromycin, chloroquine. Again, right now, the value of these medications is still unclear, but there are over 500, maybe probably even more to this date, clinical trials that are in progress, so we're still waiting results. There is a medication called remdesivir. Supposedly, according to Dr. Connolly, it's not available in Canada, but it is in the States, and they have there was a study for the first case in the US, I think it was in the Northeast, where they used it on a patient in the hospital, and the patient showed remarkably good outcome within a day. So a lot of work being done there on that. Here are some articles that I looked up with regards to the different medications that have been tested, that are still being used, and some information for you to look at. So come back to this slide and look at some of these articles. Not easy to read, of course, especially if we don't have a really strong science background, but at least we know that there's a lot going on out there. Now, in our world, in our world, Alberta Health Services has been doing a lot, especially when it comes to personal protective equipment guidelines. So going to the Alberta Health Services website and just working your way through that. The link is there at the bottom. This, of course, is focused on hospital care of patients, so accommodation, hand hygiene, personal protective equipment, the gowns, personal protective equipment, gloves, facial protection, going through these. And of course, if you go to that website, each of these links takes you to a different PDF document. In some cases, also a video, which I'll show you here in a minute, and goes through the eye protection, N95, and then, of course, handling patient care equipment and items. So take your time and read that. Patient ambulation, outside rooms, bed spaces. So this is more of a hospital-based information sheet, but still very important. Some of us who work in the hospital obviously have to go through that. So I'm just this is the link to the Alberta Health Services site for donning and doffing, and I'm just going to show you the video here.
Personal protective equipment is essential to prevent the spread of disease-causing microorganisms. Today, we'll learn the ins and outs of donning and doffing, or putting on and taking off personal protective equipment, which is critical to limit the spread of microorganisms and prevent self-contamination. The procedures you are about to see are to be followed by healthcare workers in hospitals, clinics, and other healthcare settings. The equipment may vary, but the principles and techniques should remain similar to ensure caregiver safety. You'll see it's not hard to do it right, but it can't happen just like that. Putting on personal protective equipment should be guided by two main principles. One, keep the PPE clean when putting it on, and two, make sure the PPE is put on the right way so it can protect you. Hand hygiene is the most important element in reducing the spread of disease. This is why it is the first step in donning personal protective equipment. Alcohol hand sanitizers are the preferred method of hand decontamination in healthcare settings. However, if your hands look or feel dirty, soap and water is required as alcohol is unable to kill microorganisms in the presence of organic material. Cleaning your hands before putting on your equipment is critical in preventing contaminating the equipment and potentially the patient. Next, gowns are worn to prevent the soiling and contamination of clothing and arms. Washable isolation gowns are sufficient to stop the transmission of disease unless substantial splash or spray is expected, in which case a water-resistant gown should be chosen. Gowns should have a long sleeve and cover arms down to the wrist. You must ensure that both ties, those at the neck and those at the waist, have been tied to adequately cover the back and prevent accidental contamination. Masks are used to prevent the exposure and contamination of the mucous membranes of the nose and mouth. A procedure or surgical mask is sufficient protection for most situations, unless protecting from a disease that is transmitted by airborne particles or if an aerosolizing procedure is being performed. You must avoid touching your face when wearing a mask and/or eye protection. To fit your mask correctly, first form the soft metal strip around the bridge of your nose. Second, place the ear loops or tie the surgical ties to your head to ensure a snug fit from the mask. Finally, pull the bottom of the mask down underneath your chin. This ensures that the mask is covering as much of your face as possible and is protecting your nose and mouth from droplet contamination. An N95 respirator mask is used to protect healthcare workers from airborne diseases and during aerosol-generating procedures such as intubation and bronchoscopy, when certain diseases are suspected, for example, pandemic strains of influenza like H1N1. The following is the correct procedure for donning a duckbill shaped or styled respirator. Begin by identifying the top surface of the respirator or the side intended to face upwards. Open the respirator to form a wide cone. Slightly bend the nose wire to form a gentle curve. Then, using index fingers and thumbs, separate the headbands. While holding the headbands with your index finger and thumbs, cup the respirator in one hand and pull it to your chin, and pull the headbands up over your head. Position one headband at the base of your neck and under your hair if possible. Position the second band on the crown of your head. Conform the nose piece across the bridge of your nose by firmly pressing down with your fingers. Continue to adjust the respirator and secure edges until you feel you have achieved a good facial fit. Finally, you'll need to perform a fit check. This must be done every time a respirator is donned. Forcefully inhale and exhale several times. The respirator should collapse slightly upon inhaling and expand upon exhaling. You should not feel any air leaking between your face and the respirator. This is a sign of a good facial fit and a successful fit check. If the respirator does not collapse and expand, or if air is leaking out between your face and the respirator, then this is not a good facial fit. You should adjust the respirator until the leakage is corrected and you are able to successfully fit check the respirator. Here's a tip for achieving a good fit. You may also choose to position both headbands at the top of your head 1 to 2 inches apart for a tighter fit. The following is the correct procedure for donning the 3M N95 respirator. Pre-stretch both top and bottom elastic straps before placing the respirator on your face. Cup the respirator in your hand with the nose piece at your fingertips, allowing the elastics to hang freely below your hand. Position the respirator underneath your chin with the nose up. Pull the bottom strap over your head, positioning it around your neck, below your ears and under your hair if possible. Pull the top strap over your head, resting it high at the top of the back of your head. Place your fingertips from both hands at the top of the metal nose piece. Using both hands, mold the nose piece area to the shape of your nose by pushing inward while moving your fingertips down both sides of the nose piece. Pinching the nose piece with one hand may result in improper fit and lessen effective respiratory performance. Perform a seal check prior to each wearing. First, place both hands and completely cover the respirator, then exhale. Be careful not to disturb the position of the respirator. If air leaks around the nose, readjust the nose piece. If air leaks around the respirator edges, adjust the straps along the sides of your head to perform a better seal. Eye protection is used to protect the eyes of a healthcare worker from exposure and contamination. Disposable or reusable safety glasses, full face shields, occlusive goggles, and surgical masks with face shield attached are all used in healthcare settings. They are able to stop the transmission of droplets from any direction, including the sides, top, and bottom, as droplets approach the healthcare worker. It's important, however, that if you are using eyewear that requires a seal around the face, that none of the hair breaks the seal. Personal glasses are inadequate as they do not protect the sides, top, and bottom of the eyes. Clean, non-sterile examination gloves in the correct size are key in preventing contamination of healthcare workers' hands. Gloves should be changed between patients and between care activities on the same patient. Do not reuse or wash gloves. Any gloves that rip, leak, or become contaminated should be changed as soon as possible. Make sure that the gloves cover the cuff of the gown. Remember, gloves are an additional measure to prevent disease transmission and never a substitute for hand hygiene. Donning of your PPE is now complete. Let's just recap and remember a few points. Donning always begins with hand hygiene. A gown is put on, tied at top and bottom, and then a mask is secured in place and eye protection is placed over top of the mask. Finally, gloves are applied, ensuring that the gloves cover the cuff of the gown. Mask and gowns work as long as they are dry. If they become wet, change them as soon as possible. Doffing, or the removal of personal protective equipment, must be performed in a method that prevents you from contaminating yourself or your environment. You must remove personal protective equipment in the following order to ensure self-protection. Glove removal is the first step in correctly removing your personal protective equipment. Carefully lift up the base of one of your gloves and pull it off of your hand. Ensure that you do not reach underneath your glove or contaminate the soon-to-be exposed hand with your dirty glove. Next, using your ungloved hand, insert a fingertip or thumb tip and lift up the cuff of your remaining glove. Carefully pull the glove forward and off of your hand. Do your best to keep your exposed hands off the outer surfaces of the gloves as you remove them. Now your gloves are inside out and you can carefully put them in the garbage. Glove removal is not complete until you clean your hands. Every time you remove your gloves, you must clean your hands to prevent the transmission of microorganisms to yourself and to the patients you are caring for. Now that your hands are clean, it is safe to remove your gown. Untie the strings at your neck, followed by the strings at your waist. The reason for this is the gown strings at your waist are more likely to be contaminated from environmental sources than those at your neck. It is better to proceed from your neck to your hips to prevent self-contamination. Next, carefully insert your hand at the top of the gown in the front or shrug the gown down from your shoulders. Pull it off one arm at a time. Ensure you do not let the gown touch your clothes. Then carefully turn the gown inside out so that the clean inside surface of the gown is now on the outside. Carefully roll up the gown in a way that minimizes air disturbance and place it directly into the laundry hamper. Disposable PPE must be thrown into the garbage directly after use. As with glove removal, the final step in gown removal is the decontamination of your hands. Cleaning your hands after taking off your gown prevents dirty or contaminated hands from touching your face during the removal of PPE. First, all personal protective equipment that is on your face should be removed by the arms, the straps or ties at the back of your head. Do not grasp the front of any facial PPE. Hold goggles by the straps or arms at the sides. Pull forward off your face in a smooth, uniform manner. Face shields should be removed like all other face PPE by handling the sides and back only. However, due to the length of the shield, individual technique has to be changed to make sure you do not contaminate yourself with the shield. If reusable eye protection has been worn, then be sure to clean it at the point of use with a hospital-approved disinfectant before you take them out of the room. N95 respirators can be removed in a few easy steps. Lean forward slightly, pull bands over your head and stretch arms forward, dropping the mask into the garbage. If your mask is held in place by ties instead of elastic loops, untie the bottom strings first. Then carefully untie and hold the top strings to remove the mask from your face. Then put the mask in the garbage. Hand decontamination is now required to complete the successful removal of your PPE. So one last time, clean your hands. Here's just a few things to remember to avoid. Often shortcuts are taken because healthcare workers are busy, especially when a patient is on isolation. Here are a couple of mistakes that healthcare workers often make. First, they avoid or forget to tie the bottom strings on a gown or isolation gown. This leads to two potential problems. One, gowns left open expose the back of the healthcare worker to contamination from the environment. Two, often when gowns are left untied, they lead to the opportunities for healthcare workers to contaminate their own clothing or even reach inside their pockets. Another common mistake is the failure to take off your gloves prior to untying your gown or removing face and eye protection. This is the highest risk of self-contamination when removing PPE. Always take off your gloves and clean your hands first prior to removing any other piece of personal protective equipment. Masks should be removed and disposed of if they are not in use and not kept around your neck or chin for reuse. Do not try to save or store any piece of disposable personal protective equipment. Disposable eye protection should be thrown away after each use. If reusable, it should be placed inside a soiled equipment hold until it is able to be cleaned as required. Linen and garbage must be placed inside the appropriate container. Gowns, towels, and other pieces of linen hanging over the sides of linen containers increase environmental contamination and also increase the chance of a healthcare worker contaminating themselves when walking past. And please don't overfill containers. Now that you are aware of proper procedures in donning and doffing your protective apparel, you can work with full confidence protecting yourself and those around you.
All right. So obviously some of the things that we do a little bit differently in dentistry is, or oral surgery, is we do wear a head cover. I was actually kind of shocked when I watched this video and saw that no one had head cover. Now this is mostly for nurses or healthcare workers, assessing patients, treating patients in rooms, so on and so forth. Obviously, in the operating room, we all have our head covers as well as the sterile, water impermeable gowns, sterile gloves, the N95 masks for aerosol generating medical procedures, and eyewear. So we'll go through that obviously in a little bit. So this part is a little bit I think important because there is a lot of misinformation out there, and I wanted to summarize it in a few slides to help kind of set some of the record straight. And again, this is from all the research I've done based on what I've heard and some of the articles that were published. So early studies were showing that males were more likely affected by COVID-19 or the coronavirus. However, current studies show an equal distribution between males and females. Initially, there was some evidence that people with blood type A were more prone to the disease as compared to type O blood, but that's no longer valid. There was a miscommunication. It was based on something said by the French health minister regarding NSAIDs. These were earlier reports about NSAIDs not being used to treat patients who have COVID-19. However, this is no longer considered valid. And current research, and again, it's limited, right? It's only from a few months, is not showing any fetal transfer. So no current information or no current risks to fetal transfer. Genetic changes of the virus appear to be occurring. However, scientists are saying that it's not a major factor at this point in time. The virus is not found or has not been found. I'm sure it will be at some point, depending on how many people get infected and how many samples they do in the blood and in stool samples. There are many clinical trials, as I mentioned, in progress, and they're testing the hydroxychloroquine, the Kaletra, remdesivir, interleukin-6, especially for the more critically ill patients. And Dr. Conley had mentioned that there's some hope in the use of fractionated plasma acting like a hyperimmunoglobulin as the number of exposed and recovered individuals increase. So they're going to be utilizing those individuals in order to get some other method of treatment. There was a Clinic Infectious Disease article published in March that reported that the highest risk factors for COVID-19 to healthcare workers was poor hand hygiene and improper PPE. And this study came from assessing healthcare workers who were infected in China, especially in the epicenter of the virus. And again, the poor hand hygiene and improper PPE were the most common causes for healthcare workers to become infected. Hence, a lot of information right now on proper PPE. Dr. Conley also talked about this particular article by Wolfel et al. That's published in Nature. And what this article, it had some strengths about it. So the main thing that this article showed, and it's a very complicated, very scientific article, was that on day 8, patients with positive culture started showing IgG production, so that's your antibody production, and there was a decrease. I'm not sure if it was a disappearance, but there's definitely a decrease of the viral load. So actual viable or alive, cultivatable, culturable virus disappeared around day 8. And so that was supporting the theory that by day 10 to 14, from the actual date of onset of symptoms, the patient has become an immunocompetent host. So day 8 is the time where our antibody or the patient's antibody production is increased and actual alive virus is not found. And so that person, after, say, the 10 to 14 day of isolation, is now no longer shedding a live virus. Even if they're coughing, even if they're sneezing, there may be virus in those droplets, but that virus is actually not alive. So they're they're shedding dead virus. And that's really important to know. And so there's a lot of questions about testing everybody. So the test all strategy. And Dr. Conley mentioned that that's actually not a great idea, because if an asymptomatic patient is infected and they're tested too early, then they're actually not displaying or producing the virus yet. So there's a high risk of false negative results in testing everybody, especially those people who are not showing symptoms. So then you've got a person with an undetected presence of a live virus, because they actually haven't been producing that yet. The patient doesn't go into self-isolation, as they should, because they think they're negative because of the false negative. And then 5 days later, which is the median time of symptom presentation, 5 days later they start actually developing the symptoms. So now, for the past few days, they're thinking they're negative because it's a false negative, because they were asymptomatic and we tested them too early, but they actually were infected and they've probably come into contact with people. And this could be just, family. Social distancing in family is a little bit more difficult. Maybe in the environment, they're still walking 6 feet or 2 meters apart from others. But when talking to family at close range, kissing them, or, being social with them, they actually are infecting others. So that's where it was suggested that this test all strategy, even asymptomatic patients, is actually not a good idea, because we'd be testing them too early and we'd get higher levels of or risk of false negative results. There's a big controversy still with regards to whether this virus is droplet versus aerosol spread. And I can tell you from everything that I've read so far, to this day, they do not feel that it is an aerosol spread virus. Just the behavior of the virus itself and the studies that have shown actual location of live virus from an infected person has really fallen into more of a droplet spread type of spreading of the virus. So there are some studies out there that are implying that the virus can be carried by aerosol droplets that are less than 5 micrometers in diameter. However, a lot of these studies have actually been a bit rejected or debunked there, because what they have shown is that that virus that they're seeing, that they think is being transferred by aerosol, is actually not live virus. So it could actually be just shedding of dead virus. And they do studies like RT-PCR studies that actually amplify the presence of virus, but it's not necessarily testing live virus presence. So right now, the thought process is the virus is droplet spread, larger droplets, by coughing and sneezing, and generally landing within a meter of an individual. And 2 meters or more is a safe distance to be away from them. Now, they have done other studies that I read about where they've had like really different environments where they're testing this aerosolization. It's a closed environment. There's no circulation of air. There's no exchange of air. There's no windows, doors, anything like that. And a person who's repeatedly coughing in that environment, then obviously the virus is going to be carried not only by large droplets, but also by smaller droplets, and it may spread around further. So that's not the usual scenario that people are in. We don't live in a vacuum. So it's still believed to this day that it is a droplet spread virus. Okay, so coughing and sneezing will produce a variety of droplet sizes, generally the larger droplets, and they fall within a meter or so of the patient. So keeping that personal distancing of a person at least 2 meters or 6 feet is recommended. When someone is persistently coughing and sneezing, they can definitely produce a mixed bag of droplet sizes. So there could be smaller infectious droplets. And in this scenario, wearing a mask, it should be a non-surgical, it should be it does not have to be an N95 mask in this scenario. For the patient to be wearing, so that they're not spreading this virus around. And from us, again, the 2 meter distance from this person and avoiding crowded spaces is also recommended. This is a diagram that I got off of this particular article from this particular article, the International Journal of Oral Science from 2020, Peng et al. Transmission routes of 2019 nCoV and controls in dental practice. And you can see if you had an infected person, obviously coughing and sneezing, you've got droplets. Now they do talk about airborne, but at this point, just them coughing and sneezing and us being in their world by performing procedures, dental procedures, oral surgery procedures that actually produce aerosols, then we have direct contact with that person. And this is where you can have contamination of self, contamination of assistants, and of course, contamination of surfaces. So it's really important, obviously, to practice proper PPE, and I'll go through that in a second. So aerosol generating medical procedures and dental procedures, if you want to break them down, the Alberta Health Services have great resources. I'm going to show you a couple of links here in a second for the donning and doffing. You can print these posters out, laminate them, have them in your operatories, so that if you are going to be performing procedures and you obviously are producing aerosols, you want to have proper PPE, and I'll show you those in a sec. In the medical world, obviously, anyone that's working in the patient's oral cavity, upper GI tract, nasal cavity, intubation procedures, things like that, they are all wearing N95 masks. So if I were to click on this donning, try to bring it over here to you guys. Right. So there's your hand hygiene, the gown, procedural masks, N95 respirators, eye protection, gloves. If I were to go down here, page 2, I think that's the one. And then doffing. Right here, taking off the PPE, I should say, gloves, hand hygiene, gowns, hand hygiene, eye protection, face shields, masks, hand hygiene. So you can actually print these out and have them laminated and in your operatories if that helps you guys out. And I would highly recommend it. We definitely have those at Contours. So the highest risk of self-inoculation is still improper removal of PPE. So some of the new things that Alberta Health Services is also promoting, especially in a hospital environment, is sort of a buddy system procedure where you have someone that is in PPE helping another person that has maybe just performed a procedure to help doff by untying the gown from behind instead of people reaching behind themselves, up, down, helping out with mask removal and things like that. Multiple hand hygiene steps during the doffing process, as you saw, that's crucial. It's almost like mini scrubs in between each step. There was a recent systematic review from the Journal of, I think, Hospital Infections 2020 from last month that showed that the coronavirus can live on plastic for up to 9 days. Previous studies on or information on coronavirus on plastics was just talking about a few hours to a couple of days. So now they've actually seen that it can last for 9 days. So really important to know that. So PPE in our practices, obviously in our practices, according to Alberta Dental Association and College, we are not seeing symptomatic or infected people in our practice. Anybody who falls into that category. What we've implemented at Contours Oral Surgery, we have pre-screening phone calls for patients who call in for dental emergencies. Our front desk goes through a number of COVID-19 related questions. You've seen that on the Alberta Alberta Dental Association and College memos that have come out, asking them about fever, asking them about any symptoms they may have, being exposed to anybody with symptoms or reported COVID-19. That traveling has become less and less because there's now more community transmission, but all of those questions are asked to the patients on the phone. And we just document all of that. If a patient is deemed an emergency and needs to be seen in our practice, that is actually sent as a document to them that they fill out, they sign, and they send back to our reception. We also, of course, have a personal information consent form that has to be signed and sent back to our office before we actually proceed with creating a chart, electronic chart for them in our practice, and then obtaining all the information, say from a referral or even patient information self-referral. And then those patients are scheduled for the emergency procedure. They're asked to come alone if there is a sedation involved, and the patient comes with an escort. Both patient and escort go through the questionnaire at the office. They hand sanitize. They get their temperature checked. The escort either stays in our waiting room or generally asked to just be in the building waiting area. We've got a nice waiting area for the building so that we minimize how many people are in the practice. The patient then goes to a consult room, which has been double wiped, and I perform the consultation. Anytime I'm going into the patient's mouth, I'm wearing a class 3 surgical mask, gloves, gown, and hair cover, as well as eye protection. And of course, when I'm doing any sort of procedure, then we go the extra step. So non-aerosolized procedure. In my world right now, emergency care, non-aerosolizing procedure is what I'm trying to aim for, which is simple extractions, using gauze pressure for hemostasis, minimizing the suctioning, minimizing any sort of irrigation, if not eliminating it altogether, biopsies for patients for suspected cancer lesions only. Things like that are what's going to fall into the emergency care at this time. So you can see the list. So surgical mask, class 3 mask recommended, N95s are not recommended when you're not performing aerosolized procedures. Fluid-resistant surgical gowns, eye protection, surgical gloves, or you can use exam gloves as well if you need to for just examinations, and then of course a bouffant or hair cover. However, when we're producing aerosolizing procedures, and unfortunately in our world, if you've got someone with an infection, with a broken down tooth and or root, with periapical infection leading to an abscess. Obviously, our first method of management of these patients initially is antibiotics, analgesics. However, if they've been on several courses of this and the symptoms are not changing or worsening, then we have to treat them. And in this case, we are using our N95 masks, we're using fluid-resistant surgical gowns, eye protection, surgical gloves, sometimes even double gloving, and hair cover in all cases. We never do any procedures without hair cover. So those are some of the recommendations. From a take-home message standpoint, I would tell you and reinforce, treat only emergent patients and avoid aerosol generating medical procedures at all costs in your dental office, and especially if you do not have access to N95 masks. Use proper mandated PPE recommendations for non-AGMPs to avoid wasting crucial N95 mask supply. As we know, it's very difficult to get these masks. Stay current on the literature through reliable resources. My resources currently are Alberta Health Services. I get some information from the Royal Alexandra Hospital, the surgical services, as well as anesthesia services from the hospital, and of course, for all of us, the Alberta Dental Association and College. They're also trying their best to get us all the information they can, and this changes hour by hour, day by day. So, be patient with that. And of course, practice personal distancing and self-isolation. If you have any symptoms, as you saw the overlap between cold, flu symptoms, and this are so great. So you should isolate yourself for at least 2 weeks. even if you think it's just a common cold. It just protects everybody. And of course, like we're doing right now, communicate with your colleagues. Pick up the phone, call me at the practice, call me if you have any questions, if you're concerned about a procedure you're about to do, or with whomever you work, because we have to face this together and work together and stay educated. So I hope this helped everybody. I put this together so that everyone can have a little bit more information. I dug a little deeper to learn a little bit more, and I hope this comes in handy for all of you. Thank you for your patience and your time. Stay safe and hope to see you very soon on the other side. Take care.